Yes, thank you very much for the introduction, and thank you very much for the opportunity to be a part of this conference and speak about my results. As you already mentioned, the talk will be about the influence of pedaling frequency, and the talk will be divided into two parts. The first part is the influence of the pedaling frequency, and the second part will be about the influence of different protocols to determine, or maybe say estimate, the vLamax or VLA peak. The first study is already published, and I will present the results of this study and what we did there. We included 13 male participants, and they did 5 different sprints at different pedaling frequencies, as you can see at the bottom of the slide, from 90 RPM up to 170 RPM. And I would say the participants were active, healthy males. The tests were randomized, and between the tests were at least 48 hours. As you can see on the right side of the slide, we did a slight warm-up of 10 minutes by half the body weight, interspersed by a short break where we did 2 blood samples. I collected 2 blood samples, followed by a 10-second sprint at the respective revolutions per minute, followed up by several blood samples up to the 13th minute following the sprint. On the left side, you can see the course of the blood lactate concentration after the sprint test ended. Below the graph, you see the bi-exponential function we used to create these smooth plots, where we can see the course of the blood lactate concentration. And what we can see here is that with slower movement speeds, we have a slower increase in blood lactate concentration, and not slower, but a smaller increase in blood lactate concentration, reaching a smaller peak and maybe a little bit earlier. And this increases strong between 90 to 110 RPM and between 110 and 130 RPM, significantly, as you can see on the box plots on the right. And after 130 RPM, we kind of reach a saturation in this effect. But we can also see a difference between 130 RPM and 170 RPM. But the difference is much smaller, but we may also see an even further increase if we increase the pedaling frequency higher than 170 RPM. We did not look into this today until now, but we may assume this. Here you can see on this slide, we just looked at the change in blood lactate concentration, meaning the as you're already familiar with the equation, I think, right now. And delta BLC is what's at the top of the equation, so BLC max subtracted by BLC rest. And here we calculated the vLamax, or we may have to say VLA peak, because we see that we only can talk about the vLamax at 170 RPM, but the other vLamax are not maximal. I can maybe refer to what Benedikt Meixner just said about the maximality. We used a fixed alactic time, and as we see with the change in blood lactate concentration, we see an increase in vLamax also. What does this mean for us? We see with higher movement velocities an increased reliance on anaerobic metabolism, and specifically set of anaerobic glycolysis. We maybe or probably see an alteration in recruitment of muscle fibers, where it transitioned to more glycolytic type 2 muscle fibers with higher movement velocities. And if we want to compare between different studies, we should also always consider the pedaling frequency or the movement speed in general. When you compare studies, when we're testing the vLamax, however, it might be quite difficult for other activities than cycling, because in running, swimming, or rowing, we cannot use an isokinetic mode. Also, if we look into real-life activities like cycling, it may also be difficult to control the movement velocity as we can do when we use a cycle ergometer. However, I would still suggest if we can, we should control the movement speed. And to conclude, if we want to look into the simulation, metabolic simulations, we may not want to look at the highest movement velocity, but maybe we want to look at a movement velocity we use for our desired activity. Like if we have an endurance athlete who's maybe pedaling at 90 RPM or 100 RPM, we may want to use a test like this to look at the VLA peak in this set of muscle fibers for this specific movement velocity. Okay. From now on, I will move to the second part, where we look at the different exercise protocols. We can look at the delta BLC in all known protocols we know, like incremental step tests, ramp protocols, and sprint tests. Slide. Okay, now it moved on. And sprint tests, but it may only be possible to measure a true vLamax or VLA peak for a certain test, like sprints of approximately 10 to 15 seconds. And what we see on the right side now is there are these different protocols I just mentioned. And here we see in red a sprint test, and there's a small arrow indicating the how long the sprint test lasted. And here we see the amplitude of the change in blood lactate concentration for the sprint. And for these very short time and activity, we have a steep increase in blood lactate concentration. In blue, we see a ramp test protocol. And here we also see a high increase in blood lactate concentration, but in relation to the test duration, it's smaller than with the sprint test. And it might get even smaller if we use a step test. So we can always measure somewhat of a blood lactate accumulation rate, but the longer the test, the smaller it will be. However, despite these differences, it might be possible to estimate the vLamax using a ramp test. A ramp test is typically used to determine the VO2 max. So if we would be able to measure the VO2 max and the vLamax in just one test, would be quite helpful. And like Professor Wackerhage said, we wouldn't look at the test result with both eyes. We could look at VO2 max and the vLamax with just using one test. And the idea that we can do so is actually from Professor Heck and colleagues. Based on the metabolic simulations, they simulated a connection between the post blood lactate concentration following a maxima ramp test and following a sprint test. And what you can see on the right side is it's not a linear correlation, but an exponential connection between the blood lactate concentration following the ramp test. And so we can predict the vLamax using the maximal blood lactate concentration following the ramp test. So the idea was now that we wanted to test this, and we did so with 22 male participants. They performed a ramp protocol with an increase of 25 watt every 30 seconds, and we compared these results to the 10-second isokinetic sprint. The blood lactate samples were collected immediately after the test and up to the 9th minute following the sprint and up to the 13th minute following the ramp test. The plot shows the ramp test we conducted with an individual warm-up followed by ramp test with we aimed for a test duration of 8 to 12 minutes, like typically done with a ramp test to determine the VO2 max. And we compared statistically the change in blood lactate concentration following the ramp test and following the sprint test. And if the hypothesis is true, we should see a correlation between the peak blood lactate concentration following the sprint and following the ramp test. In this population, we did not see a significant correlation. You maybe can say there's a slight positive correlation, however, not significant, and it's not as good as we expected it to be. That's maybe due to the inexperienced participants we investigated, and I think it's quite reasonable to think that a few seconds more or less in a ramp test could have a huge impact. In a discussion with Professor Heck, he always emphasized how important it is that we have a truly maximal ramp test. So if someone is maybe inexperienced and the test is terminated too early, maybe 10 or 20 seconds more, if we think about the steep increase following a 10-second sprint, I think 10 or 20 seconds more in a ramp test can also result in it can have a major impact on the BLC peak following the ramp test. So maybe that's the reason we didn't have a good correlation in this population. However, what would this mean? Is it only feasible for and with top athletes? I think it would be I think it's would be a shame if we cannot use the ramp test. There's maybe this one economic advantage we have, but there's also another benefit, and that is the simpler coordinative requirements we have with the ramp test. Because if we look at the sprint test, when can we talk about we really have a all-out test? On the right, you see what we may consider is a really all-out test. We have a steep increase with one peak, followed by a decrease of power. However, sometimes we see something like this. The increase in power is somewhat decreased, and we do not have a smooth decline. Sometimes we may see a peak in power after 5-6 seconds, and not really on the onset of the exercise. So what could be the reasons? It could be that the participants are using somewhat of a strategy, especially when we use a longer test, to save some energy. They are maybe hesitant or even anxious about the sprint test, and they are, or they maybe are inexperienced. So in this 10 seconds, we may want to, we always have to, well, we want to see an all-out test because there's not much time to get the energy in we want to measure. And if the participants are not well familiarized with the test or maybe are hesitant, that could also be a reason we may not have a valid sprint test. And another question is the sprint test even safe to perform for the participant I want to include? What we also think of if we want to use a ramp test is we think of participant and not participants, but patients. So right now we are always talking about athletes, but measuring the vLamax or VLA peak may be also interesting for patients, especially this was already mentioned today for maybe diabetes patients or patients with lung diseases who have a changes in energy metabolism. So we looked for let's say, an alternative test than the traditional ramp test, and therefore we picked the steep ramp test and are currently doing a pilot study investigating the correlation between a delta BLC of a sprint test and a short ramp test. And as I already said, the steep ramp test, which has a 25-watt increase every 10 seconds, and it's a test that was already used with heart failure patients, COPD, cancer, and as cystic fibrosis patients, so it should be safe. And right now it is used to measure the maximal power output to design a training intervention, and we see a good correlation between the peak power and VO2 max. To date, the change in blood lactate concentration following this test was not studied, and that's what we did in this test. We think it may be more suitable than a classical ramp protocol because we have a shorter duration, and yeah, that's could maybe help to see a closer correlation between the change in blood lactate concentration. We included in our pilot study 10 female participants who performed a 10-second isokinetic sprint at 130 RPM and a steep ramp test with an individual steep increase with the aim of reaching the end of the test after 60 to 90 seconds. As you can see on the right side, the black line shows the 10-second sprint and the gray line, the steep increase of the steep ramp test. Between the tests were at least 24 hours, and the tests were conducted in randomized order. On the left side, you can see the power and change in exemplary data set of the power and change in blood lactate concentration following the sprint in black, and in gray the steep ramp test. So we see a higher increase in blood lactate concentration following the steep ramp test as expected because of the longer test duration. But on the right side, you can see the correlation between delta BSC following the steep ramp test and the sprint test. And here we found a significant correlation of 0.84. So we were able to, in this test, we have a clear indication that it may be able to estimate the vLamax using a steep ramp test. And I already talked about patients. And here we have an exemplary data set of a patient with chronic bronchitis. He was hospitalized for a clinical examination to determine the need for lung valves. And with this patient, we did the same procedure, a 10-second sprint, however, with 90 RPM. So it will be easier for the patient to read the desired movement velocity, the 10-second sprint, and the steep ramp test. And both tests were, I would say, done really well by the patient. The sprint test also seemed safe. However, as I already said, and here you can see this is the power data I showed earlier, we cannot be sure if the test was really all out. So to conclude, the use of a ramp test to estimate the vLamax appears to be possible, but with the sprint test, it presents some challenges we may want to look into further. And a further challenge for the future might be the determination of the vLamax or VLA peak of patients. But here, a ramp test could be a safe alternative. And here I'm at the end of my talk. Thank you very much for your attention, and I would really like to answer your questions.
Excellent. Thank you very much, Ralf. Really nice to see the inclusion of the vLamax into more disease populations. I think it has real good transferability from more performance physiology to health physiology, and that's really nice to see. Got a couple of questions in the chat. Got one for you here as well. So going to like the first part of your talk, you say about the differences in cadence and maybe with your tests. Do you think more as a practical application going forward then, it's better to replicate the test of the cadence of the real world? So you say if an athlete is 90 revs per minute, is it better to do the test at 90 revs per minute, or do you think it's better to standardize the test at 130, 150 revs per minute for everybody? So I know you mentioned that there will be some significant differences. Do you think those differences are really important when maybe prescribing training or identifying adaptations?
I didn't think into training until now. I think for testing, we should, as I already said, consider the movement velocity, and we may want to consider for which activity we are testing. So especially when we want to use the metabolic simulation, I think it's best to use a movement velocity that we also use for the activity we are testing for. Yeah, I think I kind of lost track to all the questions that were inside what you were talking. But to conclude, I cannot say what we should do in a training setting. I think that's something we may want to look into in the future.
Excellent. So we've got one from Dr. Oliver Quitman. So he says, so in their data previously on roughly 70 runners, they observed the same non-significant correlation between vLamax and ramp test blood lactate concentration. So do you think that with reference to obviously HEC 2003, that there is two distinct characteristics? Obviously, vLamax describing the glycolytic power, but then also the ramp test blood lactate concentration maybe measuring glycolytic capacity. So the differences between glycolytic power then and glycolytic capacity. Do you think that might be the differences between the two tests?
Yeah, that's a really good point, I think, because we just look at the chat, because there should be it should be clear that we are measuring two different things when we look into glycolytic power and glycolytic capacity. So that's quite true. So I think, and maybe that's the reason why the shorter test is even more suitable, because we have to generate this power in a much shorter time than when we increase in the ramp test with smaller increments. So I'm not sure how I would just like to read the comment again, okay?
Yeah, that's fine. Yeah, no problem.
Okay, yeah. I thank you very much, Dr. Quitman, for the question. I think yes, there are two different characteristics, and we maybe do measure two different things with the ramp test and the sprint test. But what I also think with the steep ramp test, we may be able to be close enough to the vLamax.
Yep, I would somewhat agree with that as well. So going to you had a correlation where you didn't necessarily see the difference. I know you mentioned that maybe it might be down to your population, maybe being more recreational or amateur athletes. So do you think we're going to see a more stronger positive correlation with elite athletes, or do you just think we might see the same difference?
I really can't say. I think that's maybe would. I think, well, the idea comes from the simulation of the energy metabolism, and if we agree that this model is true, then we should see a closer correlation. It's maybe not linear, because we saw it in the graph that it's more an exponential correlation we should observe. But I really can't say. I think I'm not sure. Dr. Quitman wrote something about their data of 70 runners. I would be really interested if those were more experienced athletes than we used. Maybe he can answer this question, and maybe he can give you a question to this question and answer to this question.